Okay, so picture this. You're on your shift. You walk in to check on your patient who's recovering from surgery, they've got some pneumonia, and all of a sudden, they're agitated, restless, and just confused. So what do? What is the very first thing you need to check? The answer might not be what you think, and on the NCLEX, getting this right is everything. To really nail this, we got to go back to the basics. So let's dive right in. To understand what's going wrong with our patient, we need to take a super quick trip down the airway. This is the bedrock, the stuff you absolutely have to know cold.
Now this shows you the whole journey. Every single breath you take starts right up top in the upper airway. Think of it like a high-tech conditioning unit for air. Its whole job is to warm, filter, and humidify that air, getting it perfect for the delicate lung tissue down below.
Okay, as we travel deeper, down to the microscopic level, we meet this absolute superstar molecule called surfactant. You know how a bubble needs that soapy film to keep from popping? Well, surfactant is kind of like that for our lungs. It coats the inside of our tiny air sacs, the alveoli, and keeps them from collapsing when we breathe out. Without it, we're in big trouble.
And here it is, the final destination. This is where all the magic happens. See, oxygen just drifts across from the alveoli right into the bloodstream, and at the same time, all that carbon dioxide waste we don't want comes out of the blood so we can breathe it out. It's a beautiful, simple exchange that keeps us alive.
All right, now that we've got the basics down, let's connect this all back to our patient. This next part is all about spotting the warning signs, the red flags that tell you to act, and to act fast. Okay, so here's the absolute money slide. Remember our patient who is restless and confused? Well, that change in mental status is very often the first sign of low oxygen or hypoxia. Why? Because your brain is an oxygen hog. It needs a ton of it to work right. So way before the oxygen monitor starts beeping, the brain is already sounding the alarm with things like anxiety and confusion. Now let's compare that to these signs. On the left, you see cyanosis, that bluish color around the mouth. That is a late sign. If you see this, your patient is already way behind the 8-ball. And the clubbed fingers on the right? That tells a totally different story. That's a sign of chronic hypoxia, something that's been going on for months or even years. You know, there are some sounds in nursing that make the hair on your arms stand up. Stridor is one of them. It's this loud, high-pitched, almost musical sound that you hear when the patient breathes in. It is literally the sound of air struggling to get through a blocked upper airway. And I really cannot stress this enough. If you hear stridor, you don't wait, you don't chart first, you act. This is not just a red flag, it's a full-blown 5-alarm fire. This is a life-threatening airway emergency that needs immediate help.
All right, let's switch gears and tackle a topic that trips up a ton of students on the NCLEX, the VQ mismatch. It sounds complicated, but it's really just about the relationship between air getting into the lungs and blood flowing past them.
Let's make this super simple. V is for ventilation, that's the air. Q is for perfusion, that's the blood. In a low VQ or a shunt, you've got plenty of blood flow, but something is blocking the air. Think about pneumonia filling those little air sacs with gunk. Now, a high VQ or dead space is the opposite. You've got plenty of air getting in, but no blood flow to pick up the oxygen. The classic example? A pulmonary embolism blocking a blood vessel.
Okay, now for the most important part, the part that you'll see on every exam and in every clinical shift. We know the problems, so what are we going to do about them? Let's talk about priorities. Okay, your patient is having an asthma attack. What is the very first thing you do? It's not grabbing the inhaler. Step 1, always, is positioning. You got to sit them up. High Fowler's position helps the lungs expand as much as possible. Then you give the rescue inhaler. Then you give oxygen. And then you reassess. That order is absolutely key.
And for our patients with chronic problems like COPD, we can actually teach them techniques to breathe better. Diaphragmatic or belly breathing helps strengthen that main breathing muscle. Another huge one is pursed lip breathing, breathing in through the nose and then slowly out through puckered lips. It helps keep the airways open just a little bit longer to get all that trapped air out.
Now this number, you absolutely have to burn this into your brain. This is a classic NCLEX trap. For a lot of our chronic COPD patients, their bodies have gotten used to running on a lower oxygen level. So our goal for their oxygen saturation is often 88 to 92%. If we try to crank them up to 100%, we can actually knock out their natural drive to breathe. This is a massive, massive safety point.
All right, you've done great. That was a ton of information. So now, let's lock it all in with a quick, rapid-fire review to make sure the most important stuff really sticks. You ready?
First one, you're doing your assessment and you see this on your patient's fingertips. This is a classic sign of chronic what?
You got it. Chronic hypoxia, that long-term lack of oxygen.
Okay, next up, let's circle all the way back to the beginning. What is the absolute first sign that tells you your patient might be getting hypoxic? It is a change in their level of consciousness, that restlessness, that anxiety, that confusion. Remember, your patient's brain will tell you something's wrong long before the pulse oximeter does. Always, always trust your assessment. And finally, one last critical thinking question to chew on. Your patient with asthma was wheezing really loudly, and then all of a sudden it stops. The chest is quiet. Is that a good sign? Absolutely not. A silent chest is terrifying. It can mean the airway is closed off completely and no air is moving at all. It's a dire medical emergency. Remember that and keep thinking like a great nurse.